Welcome and good afternoon. This is Brian Robson, the Medical Director here at Healthcare Improvement Scotland, and welcome to this, the fourth in our exciting lineup of QI Connect WebEx sessions for 2017. This is up to fourth since the series began. QI Connect provides an opportunity for colleagues across health and social care and beyond to learn from international leaders in the fields of improvement, innovation and integration. And we've designed these sessions to be short, accessible and recorded to be used at a time that suits you. And to help us with today's technology, good afternoon, Jennifer.
Thank you, Brian, and welcome to everyone who's joining us on QI Connect today. I do have a couple of quick housekeeping slides just to get you started. Please use the chat function that you see on the right-hand side of your screen to communicate, and I'll talk you through this in just a moment. If you are having any technical difficulties, such as not being able to hear the presenter speak, or if you keep losing connection, please message the event manager using the chat function or by pressing *0 on your telephone keypad. So these sessions are designed to be a fun, interactive learning experience, and we do encourage you to use the chat function to share any questions, comments or ideas throughout the talk. There will be an opportunity for Q&A at the end of the session. So if you just click on the chat icon, you can see the top right-hand side of your screen, and it's circled in red there. We will also be sharing hyperlinks within the chat function to any resources mentioned by our speakers today, and we'll be sharing those using Pinterest afterwards. So, we did promise a fun, interactive learning experience, so we're keen to find out where you're all joining us from today. So to do this, if you could just click on the pen icon to the top left-hand side of your screen, you can see it's circled in red there. Okay. And then click on the arrow icon that you should see down the left-hand side of your screen. And then click on the map to show us where you are just now. Lots of people in the UK, welcome everyone. Welcome, Gisela.
Wonderful to see the United Kingdom light up that way. Hello, Sophie Bilmer down in the Health Foundation in London. And great to see, hi Lisa from the US. Wonderful. Thanks very much, Jennifer, and thanks for that introduction. Now, Jennifer, I think we're just going to look now and just see who else is joining us. We've got in the series now, we've got more than 560 organisations who are joining QI Connect, which is an amazing feat. The growth of QI Connect is really astounding. But just before we go much further, let's get your fingers on the buttons again, and it's competition time. And what I'd like to do is, we've got 51 countries now joining us in QI Connect, and let's see that map, Jennifer, of the countries, or the images of the flags of the countries. Now, I'm going to read out the name of the latest country to join QI Connect, and the first one to get their arrow on the flag wins an amazing prize. So we've been joined today by the Tuvalu Islands in the South Pacific. The Tuvalu Islands. Oh, you're all heading slightly in the wrong direction, nearly. Oh, well done, Fiona Montgomery. Fiona, brilliant job up there on the top left. The Tuvalu Islands are in the South Pacific in Oceania. And it's great to have the Queen Margaret Hospital join us from the Tuvalu Islands. And congratulations, we'll be getting a QI Connect mug over to you in the Tuvalu Islands. And I'm delighted to say that we now have 16 pages of your wonderful logos. We're delighted to see your logos on QI Connect of the 562 organisations. And always delighted to show these. And we now also, of course, have the whole of NHS Scotland on the series also. And a special shout out, of course, to our universities. And we now have more than 42 universities. Great to see them. And a big shout out again to people who are joining us either for the first time or who have reached out specifically since the last meeting. Great to see Dr. Kruger's organisation, the Suhus Lillebet in Denmark. Great to see you on the QI Connect again today. Thanks, Jennifer. I'm always delighted to just highlight that we record all of the QI Connect sessions so that they can be used again. This is an example from our friends in New Zealand in Ko Awatea, who use the QI Connect recordings as part of their resources for learning and sharing together. We're also delighted just to highlight that all of the 33 previous QI Connect episodes are all available on the Healthcare Improvement Scotland website. Always worth a listen, and Jennifer will tell you a bit more in a moment about what we plan to do with them. And thanks, Jennifer. Delighted again to shout out the International Society for Quality in Healthcare, who partner with us and use the ISQA materials as part of their fellowship program. However, Jennifer has been working very closely with the Q initiative with the Health Foundation. For those of you that don't know, the Health Foundation is an independent charity committed to bringing about better health and health care for the people in the United Kingdom. And Jennifer, you're working with the Q Initiative and the Health Foundation to further extend the reach of QI Connect, is that right?
That's right. Really excited with the partnership.
Great, so we'll be doing some more work there to get the word out about QI Connect. Thanks very much, Jennifer. And just a shout out to the small but perfectly formed QI Connect team. Michelle De Felici is having a well-earned break this week, and we're joined by Olivia. Welcome back, Olivia.
Hi.
Great, thanks, Jennifer. And we're also joined for our questioner for today by Richard Hamlin from New Zealand. Richard is the Director of Health Quality Evaluation with the Health Quality and Safety Commission in New Zealand. And we'll come to Richard just shortly to ask the question of our speaker. However, please remember to tweet as you learn, hashtag HISQIConnect, and follow us at HISQIConnect. And we have Alex Sterling in the room with us to try and maximise our Twitter activity. And Graham McKenzie is always working with us to maximise our Twitter activity as well. So remember to use your Twitter. However, let me just introduce today's speaker. Our QI Connect speaker today is a radiologist by background, and he's worked at the world-famous Mayo Clinic for more than 3 decades. Professor Stephen Swensen is a senior fellow of the Institute for Healthcare Improvement in Cambridge, Massachusetts, and co-leads the IHI's work on joy in work. As an experienced researcher and widely published academic, Stephen has made it his work to study and understand how organizations work, and he's led the leadership and organizational development work as the medical director at Mayo Clinic for many years. And we're delighted to have Stephen with us on QI Connect. Good afternoon, Stephen.
Thank you so much, Brian. It is really an honor to be with all of you across the globe on this wonderful webinar and service to the world and to our patients. My message today is that the single most important and most impactful leading indicator of excellence in patient care and superlative organizational performance is the joy in work of our people doing the most important work in our organization. And it's also the biggest opportunity that we have across the planet to make that improvement, because what should be the most joyful profession in healthcare, physicians, nurses, social workers, managers, pharmacists, the whole team, has burnout rates that are too high and joy in work levels that are too low. I'd like to start with a story from a friend of mine that I trained with several decades ago. Several years ago we met, and he wasn't doing well. He described his work to me as a physician. He said, I get up in the morning, I go to work, and I load a box onto a truck. I turn around, bend over, picking up another box, and load it onto the truck. I do that all day long, one after another. I go home at the end of the day, emotionally exhausted, have a couple drinks, go to bed, and I come back the next morning and start loading boxes onto the truck. He had lost all joy in medicine. His patients suffered from it, and he eventually left the profession. It's a sad story that's preventable, that happens all too common across the planet today. And so the latest numbers from America, which are similar to most countries across the planet, are that over half of physicians are burned out. Other members of the care team aren't too far behind. A burned out caregiver is emotionally exhausted, depersonalized, callous, cynical, and have lost confidence in their effectiveness as a healthcare professional. It is such a sad story, and the only positive silver lining to this dark cloud is that it's the biggest opportunity that we have to create value for our patients and for the communities that they live in. The scary thing is that it is contagious. Burnout is contagious through members of the team, between units, between hospitals and clinics, and it's a significant organizational risk that leaders need to understand and get in front of. So what is the single most important way to increase the wound healing of a patient? Kindness. There are dozens of robust research studies on the effect of kindness to patients from nurses, doctors, social workers, pharmacists, and the whole care team. They have less pain, the fewer readmissions, and their wounds heal faster. And it's one of the first things that we lose in systems and in teams and in people who have lost their joy in work. I had a chance to meet a leader of a large medical system 2 years ago, and she told me about her son who developed renal failure, needed a transplant, and that was the kidney transplant was successfully performed in one of her hospitals that she led. Everything went well, at least from a technical standpoint. The kidney was not rejected, there were no medication errors or readmissions or complications. But these are the 7 words that she used to describe her experience, her son's experience in her own hospitals. And of course, an experience like that is one that is open up for less healing and suboptimal care. So it summarizes that basic opportunity. So burned out professionals are impaired. They make more medical errors, their handoffs are poor, their teamwork is poor, they're more likely to think about suicide, they're more likely to quit their jobs or downsize, their productivity is lower. We wouldn't want a team of burned out professionals working in our organization. And because the love has been lost from the system, the evidence is very clear that patients have poorer experience, patients have poorer outcomes, patients have poor safety, and their cost of care goes up when their physicians and the care team have signs of burnout. So it is one of the most important patient-centered work areas that we as leaders in healthcare can pursue. And in order to move from burnout to joy in work, we need to look at what human beings need in the activity that they spend more time than anything else in their waking hours, their work. Humans need camaraderie, purpose, and to feel trusted. So for example, There is deep and broad research regarding companionate love and empathy between caregivers and patients and within the teams of caregivers. And when those metrics are higher for companionate love and kindness and empathy, there's less burnout, there's greater satisfaction, there's greater productivity. Patients win on all regards, and it comes right back at the caregivers. That's camaraderie. Gallup surveyed people from 155 different countries around the planet. The #1 cause and driver of happiness for people of all colors, creeds, genomes, and phenomes was meaningful work, that second human need. And the third relates to this study and dozens more. This is an Arden House study. What they did in this retirement home is they compared in this controlled study the second floor residents to the fourth floor residents. On second floor, everyone was given a plant with a smile and said, here's your plant, we hope you enjoy it, and we'll take care of it, thank you. The residents on the fourth floor were given a choice. They came around with a tray of plants and they were asked, would you like a plant? Which plant would you like? That's great. And we would like you to take care of this plant. There was a statistically significant difference in the social interaction of the fourth floor residents versus the second floor residents, the amount of care they needed from doctors and nurses. There was a statistically significant difference in mortality. And of course, the residents on fourth floor who had more choice and control are the ones that live longer. And of course, we see this in many other huge epidemiology studies, some of the best from Europe, done in the United Kingdom, that show when people, whether they're working in factories or hospitals or the airline industry, if they have a little bit more control, they feel trusted at work and have some flexibility and are respected as partners instead of just employees or union members, have less problems with high blood pressure, cancer, heart disease, stroke, and they live longer too. So those are those three basic human needs of camaraderie, meaning and purpose, and feeling trusted. And it's the focus of this 6-point plan that I will share with you that is validated, it's evidence-based, it works in every business sector, and the most important sector for creating value is healthcare. It starts with 2 measures. We need to have an objective measurement of the esprit de corps of our staff, their engagement, their satisfaction, their burnout. We also need to measure the effectiveness of the point of care leaders who are in the most impactful position to improve joy in work of the people doing the real work of healthcare, the nurses, doctors, pharmacists, social workers, and that whole team. There are 6 actions that are evidence-based and validated, I will share with you, that bolster these 3 human needs to eradicate burnout and grow joy in work that we know improves patient experience, outcomes, safety, at lower costs of patients. These are the 6 actions I'll share with you briefly in this webinar of leaders, organizational design, commensality, pebbles, second victims, and last, individual resilience. So let's start with leaders. Nick Seibert published this research a few years ago in the Harvard Business Review. Basically, he measured the signature size of Fortune 500 presidents and CEOs on their annual reports, and he looked for a relationship between the size of the signature of the president and the effectiveness and success of the company. He found a relationship. The bigger the signature of the president CEO, the more likely the company was to fail. The more likely they were to overspend budgets, decrease in margins, decrease in market share. So the first step for success in joy in work is to hire people with small signature sizes. Just joking. But metaphorically, we measure, and we should all measure, the signature size of our point-of-care leaders. Here's some research that Dr. Shanafelt and I and our team published. We measure the leadership effectiveness through 5 behaviors of all of our 3,300 point-of-care leaders. And on a 60-point scale we found, for every point upwards, there was a 9% relationship to increase in satisfaction and engagement, and a 3.3% decrease in burnout for the staff in that work unit. It works, it's meaningful, and we track it, and we manage to that, and we place leaders as we need to. So what are those 5 behaviors? The first behavior is appreciation. Thank you for that extra work today on Mrs. Smith, that wonderful patient with her condition. Thank you for doing that. The second behavior is, I'm interested in your ideas. Tell me what you think. Let's figure out the way forward together with your ideas and all of the team's ideas. The third is transparent communication. Everyone in the unit should know what is not confidential, so as a team we can collectively move forward in the best direction possible as a team in a participative management mode, not in a autocratic mode. The fourth behavior, a powerful one, is I have an interest in your career. What do you want to be doing next year and 5 years from now? What's your dream career at our organization? And let's work together so you can have a dream career taking care of patients or supporting those who directly do that. And the fifth behavior relates to the story about this woman. Many of you may recognize her as J.K. Rowling. So why do we, of Harry Potter fame, of course. So why do we call her J.K.? Does anybody know her real name? Her real name is Joanne. Why do we call her Joanne Rowling? It's because the publishers of Harry Potter knew that if they used a woman's name on the cover of the book, the teenage boys in New York City and London wouldn't buy it. So clearly we have a long ways to go with inclusiveness and conscious and unconscious biases. And this fifth behavior is powerful. Leaders, point-of-care leaders, need to have everyone on their team feel welcome and trusted, regardless of their genome or phenome. And the leaders that deliver on those 5 behaviors have far superior results for patients. So this is actually the measurement of our frontline leaders at Mayo Clinic, of physician leaders, and you can see there's a bell curve. The ones on the left side who don't perform as well get special attention and coaching and development to see if they can improve the performance of their teams by truly, authentically living those 5 behaviors. And if we can't coach them and develop them up to better performance, then we move them back to something they're good at, because it's not good for patients. This is Dr. Martha Lacey. She's the chair of hematology. When she took over as chair maybe half a dozen years ago, the burnout rates in her division were some of the worst in our organization. And within 2 years, she flipped those numbers from worst to best, basically by those 5 behaviors and listening to her staff's ideas and then working with them together, not for them, not to them, but with them, to improve the esprit de corps of her staff. Particularly the nurses had some of the highest burnout rates, and it made it a great story. Martha takes care of herself. She's a chair of a very important department, and she works .8. She partners with a full-time administrator, a nursing leader. She works .8 so she can spend time with her 2 daughters at home and do some pottery. And so she's fully present when she's at work, and she, with her inspirational leadership and engaging the whole leadership executive team, made a difference in the patient care for hematology patients at her organization. So here's some research study from not too far from where we are in Glasgow, Scotland. This is from Newcastle, England. And the researchers at Newcastle University published this maybe, 9 years ago, found there was one thing that they could do to a cow to increase her milk productivity by 62 gallons of milk a year. I think it was 240 liters. They gave the cows a name, and they used the name, and amazingly, the productivity, the milk just kept flowing. Well, cows and humans share one thing in common. If we are appreciated and feel valued, our productivity goes up. And for humans, our safety goes up, patient experience and outcomes go up. It's basically a measure of social and emotional intelligence. And we need to understand that. People who have higher social and emotional intelligence have lower rates of burnout, higher rates of well-being. You can see the whole list here. And so do the members of their teams. It's infectious. So we actually look for people, particularly physician leaders, who have high levels of social and emotional intelligence. In our medical school and all of our new staff, before we hire them permanently, undergo an emotional intelligence assessment and a 360 evaluation by nurses and other doctors and administrators and students, not for pass-fail, but to understand how they work together on a team. And if they don't have high levels of social emotional intelligence and can't work well on team members, then they aren't safe physicians, and they will result in higher levels of burnout for team members, and we don't want them in our organization because it's bad for patients. The second major area is organizational design. How we make decisions, communicate, how our organization is connected between departments to compete with each other or collaborate makes a difference, and it makes a difference in how we feel. Sometimes we feel like this because the organization is designed to give us the answers and tell us what to do instead of seeking to understand and really wanting to find out what we would want and what we see as the best way to take care of patients. I got a chance to meet Bob Chapman several years ago. We had a public debate at the National Press Club, and Bob Chapman leads a large privately held company, Barry Waymiller. Fabulous book. It's one of the few books I've given to the great leaders that I've had a chance to work with, called Everybody Matters: The Extraordinary Power of Caring for Your People Like Family. And Mr. Bob Chapman does that. So our debate was, I came from the position that in healthcare, the needs of the patient come first. We have to be above and beyond everything else, look out for what's right for patients. And Bob countered that by saying the most important thing in an organization is that you have to treat your employees like family. And he lives that. He treats, they're highly unionized. He treats all of the employees not like union members, but like family members. He trusts them. So to design for joy in work, he saw that many of the companies that he acquired and turned around from red ink to black ink, they had time clocks. He said, take the time clocks out. The executives don't have time clocks. Don't we trust our employees? Would you want don't you trust your son or daughter? So let's run our companies like our son and daughters were staffing and working. And so I still would contend that patients' needs come first and should drive all of our decisions. But what Bob showed me is that if we don't authentically work to make our staff joyful and to treat them like family, that we can't possibly ever get the best patient care possible. Important lesson, and how he designs his organization and how you design your organization makes a difference in patient care by how joyful your staff are. This is Dr. Brad Leibovich. He's the chair of urology, and when he took over, their burnout numbers in urology were in the cellar. and he flipped them in a couple of years. Basically, he took the staff and said, and turned them from feeling like victims and employees to champions, from construction workers to architects, by saying, we're not going to be middle managers. We're not going to do something just because the board told us to do it. We're going to do it because it's the right thing. And he communicated that way. Instead of looking at processes that the organization told me how to do, he said, I want to look at what outcomes you want and let us figure out what path to take. Flip the numbers. Great leader like Martha Lacey, but he did that by focusing on the well-being of his staff and engaging them as partners in order to optimize patient care. He flipped the story from staff feeling like construction workers who were taking orders to architects co-designing the best possible patient-centered care. And there are organizational things that we all have to look at. There's some that we can't change overnight that are systemic nationally and internationally, but the electronic health record is a driver of burnout. Christine Zinski publishes research last year. For every hour of face-to-face contact in the ambulatory setting, there were 2 hours of clerical work, mouse clicks, related to patient care that doctors did. Hill's research showed that in a busy 10-hour shift in the emergency department, there were over 4,000 mouse clicks that a physician had to do. That's a burner. That's a burnout driver for healthcare professionals. You shouldn't throw up your hands and say we can't do anything about this. That's the nature of the beast. You can make a huge difference by looking at workflow, removing pebbles from shoes. Everybody should have a czar at their organization that looks at 3 things for electronic environment. Do we have to do this procedure and process for patient safety reasons or for regulatory reasons? If not, stop doing it. If you have to do it, well then make it as efficient as possible with as few as mouse clicks as necessary. And 3, have the person that is most appropriate do it. It doesn't have to be a physician or nurse all the time, and you can make huge impacts in the burnout driving potential of EHRs by attending to that. But don't throw up your arms and say we're stuck and we're helpless. How you make decisions, is it by consensus or by are they top-down decisions where you get a clay tablet with the answers? It makes a difference in esprit de corps. Be careful with financial incentives. Dr. Friedman from the Virginia Darden School of Business says this about incentives. And incentives can be a big driver of burnout and disengagement and values dissonance. If you give people money that have been donating blood, they stop donating blood because it takes it from a gift to an anonymous person in need, this purpose and meaning of humans' existence, to a financial transaction, and they stop doing it. Adam Grant, a researcher at the Wharton School of Business and psychologist, showed that when healthcare workers, students, nurses, social workers, doctors are reminded that hand hygiene prevents patients from catching diseases, they use more hand sanitizer, almost twice as much as if when they're reminded that it might prevent them from catching diseases. We're wired to think about patients more than ourselves. So let's take advantage of that and don't confuse it with money. If you pay emergency physicians more money for productivity, for complexity, and for patient experience, you have adverse outcomes that are unintended that increase the use of antibiotics for viral infections and ear infections that don't need antibiotics, and head CT scans for 6-year-old girls who bump their head, who don't meet PCAR and clinical prediction rules, and they get a head CT that costs $1,000 and raises the rates of leukemia only because doctors are disincented to do the right thing because they're getting paid for better patient experience and for productivity. And it creates this values dissonance where healthcare workers are in a system that that encourages them to do things that they wouldn't do for their own family members. So let's move from organizational design to commensality. I love this word, commensality. It means sharing a meal with someone. There's a lot of research in this area that started in the firefighter profession, a place where they make a lot of meals together and they eat a lot of meals together. And when they do, it improves team performance and camaraderie and productivity and decreases turnover. Colin West, one of my colleagues at Mayo Clinic, has studied this with a team of us at Mayo Clinic, 2 randomized controlled trials with doctors. And they were so successful in showing that it makes a difference to get together and visit and talk and share a meal that we now will buy meals for any group of self-assembling physicians in order to help with their emotional exhaustion, their social isolation, their feelings of effectiveness and cynicism, and positive feelings about the organization. All those go in the right direction when you spend a little more time with other human beings with whom you work. Camaraderie is a powerful force. So pebbles, this is the 4th area that I want to spend a few minutes on. Pebbles is basically looking for pebbles in your shoes. It's a point-of-care leader-team responsibility where you ask the multidisciplinary team that you work with and have the privilege of leading, what are the pebbles in your shoes? What brings you joy in work? What saps that joy in work? And let's work together to remove those pebbles so that you have less frustration and you can focus more on the joy of improving the lives of the patients you have the privilege of serving. But Derek Feely taught us that we need to do this and we need to listen to understand. Not listening, waiting to get the answer, not listening, planning your response, not listening, trying to explain why something exists, but listening to understand what it is like to be on the gemba, on the front line, from the people who really know what doesn't work on the front lines, what gets in the way of the best possible experience, safety, and outcomes for patients at the point of care. Those are the people that know what those opportunities are, and we need to listen to understand. And what we found in our research is that the improvements in morale start just through the process of starting this journey down the trail. Even before you remove a pebble, even before you address a dysfunctional, broken process, there's improvement in the morale because you have the camaraderie, because the staff involved in this improvement work feel trusted. They have some control over their life. They have purpose and meaning, so their morale improves even before the conditions improve in this whole process. It's what Edwards Deming knew 50 years ago. He would go to, when he put on these national seminars, he would start with an overhead projector and transparencies and ask the people attending, what is the purpose of quality improvement? And his answer was to improve joy in work. Connection is there. And so there's a business case for quality. This is Jeff Bolton, the Chief Financial Officer at Mayo Clinic a decade ago. Now he's the Chief Administrative Officer. We did some research. We just differentiated hard dollars from soft dollar savings and basically showed in this publication that we can guarantee a 5-to-1 return on investment for quality investments. We had a $46 million 3-year rolling average return on investment. If you put $1 million into quality improvement work, you could guarantee a $5 million hard dollar bottom line savings. So the business case for quality stands on its own. What I've learned over the decades is that, as important as that is, even more important is the business case for joy in work. So this is Roger Resar, a friend of mine, also senior fellow at Institution for Healthcare Improvement. He gave me this picture. It's from the Oktoberfest. He wanted to make sure you understood that he didn't drink the whole beer. But what Roger did is he taught me that patient-centered, multidisciplinary team quality improvement work is a gateway drug for engagement and fulfillment of staff. So he helped lead a collaborative, internal collaborative of eight teams when I chaired radiology a couple decades ago. Most of those team members, nurses and technologists and physicists and radiologists and managers and administrators, are still involved in quality improvement work today because it brought them meaning and it fulfilled them. They gave him a standing ovation. We never give anybody standing ovations. They gave Roger a standing ovation because he was so generous with his volunteer time, but also because they were so proud to be able to be trusted to make improvements in the care of patients. And so this is one of the teams we had. We wanted to move our reliability from 99.999%. If we were that reliable, we'd still have 2 patient harm events a week. So we had 8 teams and a successful collaborative. One of them was related to the asset utilization of MRI scanners. We had 21 MR scanners at the time. 6 months of the Lean project bought us 7 minutes per appointment, and which times 10 appointments a day is 70 minutes, which is another appointment per day. You fill that appointment, it turns from a soft dollar savings to hard dollar savings, and the bottom line impact of $4.1 million. Hugh Smith was the head of Mayo Clinic at the time, and he said, "Good work, team, but can't you do better than that?" And so overnight, we doubled the throughput of our scanners. And then the next night, we redoubled it, and our psychiatrist told us that we could double bill for group therapy. So basically, the beauty of team-based, patient-centered improvement work is that it buys you all 3 of the human needs for joy and work. It buys you camaraderie because you're working together with other colleagues. It connects you to the meaning and purpose of your organization because you're making it better. And it gives you some flexibility and control over your life because your leader has trusted you to do this work and implement it and make the organization better for patients. And that's what we need to have joy in work. Learned from Michael Bush. I got a chance to meet him last year at the Conscious Capitalism Conference. 30 years of research in great places to work shows, in his words, the root of the tree is trust. So basically, if colleagues, caregivers in our organizations feel trusted by the organization and the people to whom they are led by, that the organization will flourish, and customers, and for us, our patients and families and communities will thrive. Even some of the purely for-profit companies, Cargill's a wonderful customer-focused organization, largest family-held organization in America. They have 170,000 people across the planet in 70 different countries. The number one thing that they focus on is not customer satisfaction. It's not their margin. The first thing to talk about with those 70 managers is employee engagement, because if they know if employees are engaged, everything else will be easy to achieve for their organization. Second victims is the 5th area. It's relatively unique to healthcare. We have opportunities every day in every country for preventable deaths and preventable harm events. And those are the first victims, the patients and the families and friends. The second victims are the healthcare workers involved in those preventable harm and preventable death events. This is Kimberly Hyatt. She was a very competent, conscientious, hardworking, intensive care professional. She was involved in the overdose of a 8-month-old child with calcium chloride that resulted in its death. And 3 months later, she was also dead by her own hands. If you look at the suicide rates just in America, last year we had a physician suicide every day of the year, 435 physician suicides. The women physician suicide rate is 2.3 times higher than the national average for women. It's one of the fallouts of burnout, and it's one of the opportunities that we want to address by, in the words of Maureen Visignano, wasting no will. After every harm event that's preventable, after every preventable death, all of our colleagues want to improve and do better, and so let's not waste that energy to improve processes and decrease the number of second victims. And last is the sixth is resilience. And so we need to first focus on what the organization and leaders can do, and then we need to look at what individuals can do. So the London cabbies, there's a really interesting research study, have bigger hippocampus. You can actually increase the size of your memory centers in your brain by studying the 25,000 streets in London, and it shows up in MRI scanners. So do our amygdala. In our amygdala, we can actually make smaller if we improve our resilience. Amygdala are where we see the stress reactors to all of the things in our lives, and if we build our resilience, the amygdala gets smaller, like the hippocampus gets larger in cab drivers. So burnout is the depletion of social, physical, and mental resources. Resilience is replenishing those buckets. Research clearly shows that laughter improves resilience. You live longer if you laugh. We should all choose to laugh more. Mediterranean diets, inverse relationship with clinical depression. Another option. Expressing gratitude improves resilience. Sunlight. It's a beautiful sunny day here in Scotland. Sunlight improves resilience. Exercise improves resilience. Walking has about the same effect as Prozac for mild clinical depression. Mindfulness meditation makes a difference. So does sleep. So do friends and family, and so does forgiveness. So all of these are things that we need to attend to, and it's a shared responsibility. So let me summarize like this. We should measure two things: the esprit de corps of our staff and the effectiveness of point-of-care leaders. We should explore opportunities with these 6 validated evidence-based actions that will grow camaraderie, purpose, and opportunity to feel trusted, to improve joy in work and decrease burnout. We know it works in many studies, and our own results show that our numbers are going down about as fast as the national numbers are going up, and we're approaching that of the general population. It works, and it makes a difference. Thank you. So, Brian, I think we're done with that presentation, and I'd be delighted to hear some comments and engage in some dialogue.
Thank you very much, Steve. That was absolutely tremendous. I would say that's probably the busiest chat function box we've had on QI Connect. So lots of comments. But let's skip straight to Richard. Welcome, Richard, and you have a question for Steve.
Yes, thank you, Brian. Steve, thank you so much. That's an inspiring and compelling talk. Really like what you said about organisational design and its value in helping bring joy to work. My question, I suppose, is, can good organisational design counteract a perverse broader system or context? So one of the things I was thinking there was the concept of commensality. And in there is sort of the idea of openness and I think some degree of vulnerability, I think, in it working. And yet we have certainly, I think, medical training and probably more broadly health professional training, which is all about competitiveness, devil take the high, positively Darwinian in its competitiveness. And, we've socialized this sort of, these sorts of attitudes, and then we're sort of saying, well, actually, be vulnerable, having told people not to be for the first 10 years of their career, as it were. So I maybe give you, if you give some thought about how that might work.
So Paul Batalden taught us that every system is designed to get the results it gets. And so we take doctors, for instance. So pre-med students have above average mental and psychological health. and even though pre-med is not an easy run. And then as soon as they get into medical school, and then the training after that, we squeeze out that vitality and idealism and energy, and their burnout rates are high. So in fact, younger physicians have higher burnout rates than older physicians, and women more than men. So the system is designed to do that. And can we change that easily? No, but you change culture one behavior at a time. If you're serious about something, you measure it, whether it's esprit de corps, whether it's leader's capability, and then you manage to it with discipline and intentionality. All of this makes a difference. You have to start where it makes the most sense for your organization. There are big national issues that are hard, but there are medical schools now that are pass-fail. Pass-fail grading actually gives you better results than graded systems because it increases social interaction if you're pass-fail. If it's a A, B, C, D grading, then you're my competitor, Richard, and you're not my collaborator.
Sure.
So all those design features make a difference, and we need to be thoughtful about how we use them.
Thanks so much.
Thanks very much for that, Richard. Steve, I mean, so many great comments. So, Julie Allen from Northern Ireland and Dean from Ayrshire saying it's an inspiring talk. We also had a great deal of interest in the dogs and the cats, and Caroline Chalmers, Service Improvement Coordinator from NHS Orkney, said anything involving dogs must be good. So we've got a few comments around the virtual nature of staff and the fact that staff don't get to meet together over coffee, etc. And we've got a comment here from Pauline Johnson, Practice Development from Greater Glasgow and Clyde, backed up by Fiona Montgomery, Deputy Director at Scottish Government, and also Wendy Copeland-Blair from Merseycare NHS Trust, all asking a question about when staff are working in quite different teams and different physical geographies, and there's a lot of reliance on agile working and technology, how do you keep joy in work?
So first of all, we've done some research, and there's plenty of it that shows if employees, if caregivers in an organization have some flexibility and control over where they work and when they work and how much they work, that they're more engaged, more joyful, and have a relative immunity to burnout. So that's a good thing. However, we have to do some things like this webinar where we can't be in the same room. Human beings need to contact each other. When you shake someone's hand, your oxytocin goes up, your trust level goes up, your social connectedness go up. So if you want to have highly functioning teams and a learning organization that is high in social capital, the trust and interconnectedness of people, you have to get face-to-face. If you want an effective improvement team that crosses boundaries geographically, you have to at least start with a face-to-face meeting. If you add food, it's even better. But if you think you're going to consistently succeed with teams of people that don't get together and don't know each other and don't talk about the soccer game or the rugby game or their knitting or whatever, then you're wrong, because you will fail miserably. Humans need camaraderie, and they need other human beings, and webinars and conference calls don't do it, period.
Thanks, Steve. We've got a couple of questions a question that came from Arvind Varaya, who's the National Clinical Lead for Healthcare Improvement Scotland's Medicine Safety Work, also backed up by Leslie Curry, who's the Scottish Clinical Leadership Fellow with NES. And it's about how do we stop the spread of low morale. So Arvind asks, how would Steve approach a conversation with acute medicine consultants who tell trainees that they're overworked and unsupported by colleagues in other specialties and by management? How could one mentor them to foster joy?
I think the key is, I mean, any of those 6 actions would be considerations. I think the single most important for this sort of situation is that point of care leader. Whoever is the person that has the responsibility of leading that unit should sit down with them and say, not for a gripe session, but listen to understand, like Derek taught us. And so you listen to understand, you ask, what is it that frustrates you? What would be a perfect day in our organization? And then, what are the pebbles in your shoes? And then working together with the support of other leaders and parts of the organization to move those pebbles one at a time. So listening and then acting and responding. And we found in several hundred groups like this that about half the pebbles we can fix locally without a capital budget just by addressing broken processes or policies or communication methods. And then that point of care leader has the obligation to make sure that his or her next layer of leadership understands what they can't control and work to address those other drivers. So it's basically listening to understand and then acting together to make improvements one at a time. This is not a project, it's not an event, it's the way you lead organizations and work units, and we know it works. It doesn't cost money, it costs time and attention.
Yeah, well, spending that time and attention wisely with cakes. I see that Fiona Montgomery, Deputy Director at the Scottish Government, and Tim Warren, who's the policy lead for palliative care at Scottish Government, might disagree over what sort of things you need, whether it's cakes or bananas. But what they both agree on is that your quotes around change culture one behaviour at a time, measure it, manage to it, and with discipline and intentionality. That got a big thumbs up from Ros Gray, the Head of Safety in NHS Borders. Just a couple of, Joseph Dahane, who's our Visiting Clinical Leadership Fellow from Canada, has been asking, are the tools that you evaluate leadership, social skills, emotional skills, etc., are they available?
Yes. So what Jennifer will do with you after this, share with you after this webinar is all of the slides that I presented that have references and all of the diagrams, and then 3 articles that explain in detail the processes. So none of this is rocket science. It's common sense. It's just not in common practice. So we'll share with you all of the references and diagrams and first steps that might be helpful to make progress in this area. It's not like this is something new. Other business sectors have been dealing with this for decades because they know it's the best way to run an organization. Healthcare is late to the party, as we were to quality, but there's no reason we can't do it better than anybody else, and every reason why we should do it better than anybody else, because the stakes are higher than if you're mining coal or making, widgets.
Thank you very much for that, Steve. And just some great messages on the chat here. Liz Murphy, who's a rheumatologist in NHS Lanarkshire, says a big message to senior managers here: trust middle managers enough to allow them to remove the pebbles in the shoes of those on the shop floor. Thanks very much for that, Liz. Steve, I'd like to thank you on behalf of QI Connect. We will make all the resources fully available. Well done, and thank you for sharing your work in Joy in Work. Thank you very much. Now, you mentioned it's not rocket science. Well, we're delighted to say that QI Connect is getting rocket science, because QI Connect has now secured its final speaker for this year. And it's Dr. Tom Marshburn, who's a physician, an engineer, and a NASA astronaut. And those of you that saw the talk from Commander Hadfield at the London Forum last week, and you saw someone going out on an emergency spacewalk, well, Tom Marshfield was one of those emergency spacewalk astronauts and a physician. Thanks, Jennifer. We've got a total lineup now of QI Connect for 2017. You see Tom at the end of the year. However, our next QI Connect is on the 25th of May, and we're speaking to an extraordinary man. Don Norman is the director of the Design Lab at the University of California, San Diego. but he's got a long and distinguished history in design, engineering, and not least, he was a Vice President for Advanced Technology in Apple. And Jennifer and I spoke with him last week. You're in for a real ride on that QI Connect on the 25th of May. So just finally for me to say, follow us on Twitter. All the resources will be made available. And a big thank you again to Steve and the team. Thank you all very much indeed. Olivia, thank you very much, Jennifer. Thank you for problem solving.